All right, let's start. Sorry, computer problems. There'll probably be a computer guy to come in here because I think he called me and the telephone wasn't working either. So it's been a wild, crazy week. All right, so some of y'all may not have watched the video yet because of the paper. So the paper's due tomorrow. So if you haven't watched it yet, we'll talk about it more on Tuesday. But we'll have to look out for the article or the video. One thing we have, and there's several things you can quote from the video that they're still very timely. There's a lot of focus on treatment versus prevention in this video. There's some really that one lady at the end is the most quotable, but there's a guy in there that's pretty quotable as well. The one guy who talked about efficiency is encouraged. I finally got the exact quote what he said. I was on my bike, so I didn't spell the word patience correctly, but he said, "I'm paid more when I harm my patients." I don't know if I remember hearing him say that. That's inefficiency is encouraged. Now that may not be inefficiency; it may just be malpractice is encouraged. He's the one that he's saying surgeons shouldn't be making these decisions. Those that watch the video, I don't know if you noticed what I talked about. All those people in the room talking about this patient, but the goal is you have this holistic approach where it's not just the surgeon. The surgeon he kind of hinted that the money may have something to do with it, but that maybe not. But at the same time, he does make the implication that surgeons think surgery is the best solution for everything, not because of the money, because that's just the way they're built. If they see someone, they say, "Hey, I can fix that. I'll cut you open." And you're like, "Wait, it's not that serious." Like, no, trust me, I can do it. So cutting someone open when you don't need to cut them open, that's a pretty serious thing. So wait, and then a lot of this is on treatment, and the video is a lot of this is on the focus on treatment and a whole lot on overdiagnosis. They start off with what was the first one they did? I remember on that one, C-section. Y'all remember that? Pretty heavy discussion on C-sections. Then they talk about screening. Now it's interesting on screening. A guy comes in, he has an injury, maybe a sports injury, and somebody say, "Well, there could be some brain injury. Let's do this scan." As if doing the scan is no problem. And remember what he said, that's a lot of radiation. What did he say? 500 x-rays? Or what did he say? Something radical. So the screening is not risk-free. It creates risk. It's somewhat what y'all have heard about, taking biotics, taking shots all the time. Your body starts, the germs you're killing start getting resistance. That's a big deal with tuberculosis, where treatments take a lot of weeks and people don't do the full treatment, and then they have the strain that overcomes. The treatments we take can come back and harm us later. So screening is important. And what did I say on screening? Well, you're going to find stuff that probably isn't a problem, but you got to do something because you found it. And that gets into, well, so I keep giving y'all these ideas for the other. So they talked about mammograms for women 40 and older. I bet if you Google that, you would find some pretty good debates out there. So what did the video say? Does more harm than good. All right. I love what that one doctor, the guy at UCLA, I mean, he is like, I don't think he came across very well on that video. What he said was, yeah, we have all this evidence, that's great, but when you get to the individual level, evidence takes a back seat. It's like, what are you talking about? Evidence takes it. Why would it matter at the individual level? Right? Does that make any sense to you at all? For most people, it does more harm than good, but for you, we're talking just about you. You should have the test. Can y'all make any logical sense for why that makes sense? It was just like the most illogical thing. But he says, yeah, but if it's your wife, if it's your daughter, but if it's more likely to do harm than good, why would I want to do my wife more harm than good unless you have a really bad marriage or something? And the other thing he suggested is when you provide the full information, patients start making the same decision that the doctors would make with their own life. The people who know what's going on, they actually make the less invasive decision, which tells you a lot. So the screening is a big one. Well, you should see how I type mammogram. I didn't know how to spell that. Um, then they did prostrate. How do you spell prostrate? I can't even prostate. Prostate. Okay, I get those two words mixed up. Prostrate. Prostate. Oh, like that. So that one was heavily covered. You had like four people, right? So you had one had surgery, the first guy, and obviously something went wrong, but they didn't tell us. I don't know if y'all noticed that in the video. He didn't tell us what, but he says, yeah, and one of those bad things happened to me, but I'm alive. And I might be one of the 14 that didn't need the surgery, but you can see he's trying to talk himself into, yeah, I'm kind of mad I have to wear adult diapers the rest of my life, but he's probably convincing himself, yeah, I would have died if I hadn't had surgery. Yeah, that's an interesting one. Um, I don't know if you heard the numbers on how many PAC tests come back, how many people get diagnosed with cancer over the age of 70. It's a high percentage. Most of them won't die of it. So yeah, that was a big one. And I guess breast cancer before that one. That one they gave some really good numbers, and I think John Kim in his write-up he caught a lot of those numbers. So and the lady in that one, it's like, wow, I'm glad I got it done. I feel much better. I don't have to worry about it. But you don't know if it saved her life or not. Um, and then the last one, which I don't remember from the last time I watched the video. So I think I watched the frontline video. I think the video I sent you might actually have an extra section added in because I don't remember this, but heart stents. I don't remember this video. I have read about heart stents enough to know that if a doctor recommends them, I'm gonna get more insight, talk to more doctors. Um, they say for a lot of people, there's no difference in outcomes whether you get it or not. But then you have the surgery, which obviously open heart surgery is pretty dangerous. Um, so those are the ones they do. They don't do the one I'll talk about, which is my case, which is thyroid cancer. We'll see that in some of the articles. But what do they call when talking about overdiagnosis? What do they call prostate cancer? A poster child of overtreatment, of overdiagnosis. I kind of think thyroid cancer might be, but we'll see when we look at the numbers. So the video really is on overtreatment and overdiagnosis. So you can get a lot. We'll see some from the other articles. We're going to see some other quotes, but the video hits it really, really well. I don't think there's probably a transcript of the movies, so you're going to have to type really fast, but I was typing while I was on my bike. You can kind of get it to work out pretty well. And the other thing the video does, which I think is the most painful part of the video, I would put under end of life. So the video had, I guess, 4 or 5 cases. So the first guy was interesting. The doctor goes, well, do you want us to do any kind of, really go after to save your life? You're like, no, I don't want any Herculean efforts. I don't want to be in a machine the rest of my life. So he says, well, if there's a 90% chance that we can get you back after 2 months, yeah, do that. And this, what if it's a 10% chance? Yeah, do that. And you're wondering, how low are you going to have to go? So you didn't really get a sense of what he meant by don't go through Herculean efforts. The second one was, I thought pretty pretty heartwarming. The daughter's there with her mother and the dad, and they're actually battling with this. Should we do something or not? And the wife, I mean, it's just heartwarming. She says, "I want him to live." You know, obviously she does, but she says it in a way you can tell that. But I understand, you know, this is the end of his life. So that was interesting. The third one's the one that bothers me the most. The son with his mother. I don't know if y'all remember what I'm talking about there. Um, he's the one using words like euthanasia and death panels, so he's pretty upset. At one point, he says, why don't I have the power to make these decisions?" Well, obviously, it costs $5 million. Did y'all get that $5 million that he's not paying for? Wouldn't you love to ask them that question? Would you do this if it cost you $5 million out of your own pocket? So someone might say, well, human life is worth infinity. Well, it's not. Not in the way we make decisions. I don't know. Have you ever ridden on I-70 in Colorado going skiing? They could have spent another $5-10 billion to save lives on that road. That is a very dangerous road. It's one of the most dangerous. But why didn't they? Because when they build roads, they have a cost per life saved, and they decided they were going to kill more people instead of, you know, we make those decisions. You spend $5 million on that lady, that's $5 million you can't spend on other things. So there is a opportunity cost to all of these. So he kind of, I think that's the part of the movie where they might have gone too far. I thought it was really painful, him showing pictures to his mother. Did y'all see that part? Because I just thought they were almost kind of making fun of him a little bit. That obviously she wasn't enjoying the pictures, she wasn't theirs. So I think they're kind of going a little too far. I felt sorry for him. I mean, that's a painful thing. We're going through that with my mom. She's in assisted living, doesn't know anyone, just sits, you know, it's a really rough life for her. We're taking as good a care of her as we can, but she doesn't want to be resuscitated. You know, she's the one that says, no, this is not my life. I don't want this life. So she made that decision. It's painful though. It's your relatives. And then the last guy, I really liked him. Y'all remember him with the beard? He was like, take me to hospice. I'm ready to go. I don't want all this done. His I guess wife was sitting there in tears, but he had such a wonderful attitude. Y'all remember that one? Y'all, yeah, he was kind of heartwarming. So quite a bit in there that you can use. We're going to see some other things besides the video, but they gave you 4 good cases there, people making those decisions. What I want you to really focus in on, especially that third guy, is can the people who are not paying be 100% responsible for the decision? And he was saying, yes, the hospital should not have any say when my mother dies. If they can keep her alive for 1 more minute, even if it costs $1 million, they should do it. Should he have full decision? He's saying, yes, it's a death penalty, it's euthanasia, it's all these kind of things. So that may be an issue you'll have to handle. All right, so Tuesday we'll talk more. I might do some snippets from the video. Anything in the video that really stuck out to you that have seen it? It's still very current. There's not much in that video that's been fixed by the Affordable Care Act, because the Affordable Care Act just stuck more people into that system. It didn't really focus it much. They did talk about creating some of these affordable care organizations, but some of those were in place even before Affordable Care Act, and whether they're really working or not, it's hard to say. All right, so let's look at a few more of these articles. All right, so why do I show you NHS? So that's British. That's the one that's often put forward as essentially Medicare for all. Not quite as extensive, because the British is not just insurance for everybody, but it's also healthcare for everybody. It's about the most socialist system that's a one payer, one provider out there. And you discover, even though they're a lot cheaper in the US, that they're going through the exact same problems that the US has. So I just want to kind of make the point that every healthcare system is struggling dramatically. So the taxpayer-funded service, which provides healthcare at the point of use, is so precious that politicians are likely to talk of improving rather the NHS than protecting it. Overall, the service faces a funding gap. This was back whenever this was written, 2016. Doctors have gone on strike. That's true today. I don't know if y'all noticed in Britain, there's some pretty significant strikes. People needing major surgery or having to wait months and months and months, pretty serious surgery. Everywhere hospitals are struggling to make ends meet. The diagnosis is simple: rising demand for healthcare from an aging population. So this is true everywhere in the world, or maybe Africa and South America, where just aging populations in those countries are going to catch up as well. Even China, I think even, India is still growing, is going to have surpassed China, but even India is going to have the same issue. Why? Because young people just aren't having babies anymore, and everybody's aging, and that's gonna kill every healthcare system. That one's an easy one. That's like, give me points. Under the problem, paying for baby boomers, that one's a piece of cake. You just have to say it, and I pretty much give you credit. I'll give you full credit if you put a few numbers in there, find some numbers for one of the articles. That one's from the UK, but it's true. So you could certainly say, yeah, that's the UK, but it's definitely a global issue. It finally took like 3 tries. I had to reboot twice, and all right, no problem. Sorry. Thanks. They are pretty fast getting around. And it's always that guy. I don't know what happens at UTSA if anything happens to that guy, because he fixes everything. All right. But you talked about baby boomers in your first paper. Baby boomer, baby boomer. Yeah, it's a big issue. There's a lot of us, and I'm a baby boomer just barely. I just barely got in. So they're going to focus more on efficiency. Managing demand will involve not just uncontroversial measures such as more emphasis on preventive, but toxic ones, as introducing charges for services that used to be free. The UK is pretty brutal. If they don't cover it, they don't cover it. And in fact, there's a really famous case where a family had a child, they wanted to have a surgery, and the UK didn't cover it, but they could go to Italy and have it covered, and the UK said, no, you can't do that. That wouldn't fly very well in the United States. It's like, you're going to tell me what I can do with my own money? And they say, yeah, you can't, that's not covered, you can't do that. So they're pretty brutal. Would the US allow the government to say, nope, that's not covered, even if you pay for it yourself, that is not covered? That's a pretty brutal system. Countries such as Germany and Denmark have found that by reducing the number of hospitals that offer particular procedures, they can reduce complications. We're going to talk about this more. We talk about Porter, Michael Porter, and his ideas about shutting down hospitals, especially community hospitals, and going to more concentrated care in major facilities. And you saw this in the video. In fact, there was a really good quote on that of the average person, how many days they spend at the end of their life, how many people die in the hospital. We'll see a quote on this, but the one lady, she was talking about, they did a study of people who got the invasive treatment and the people who went to hospice, and who lived longer. The people who went to hospice, the people who got no treatment, just went to hospice, pain management, they lived longer than the people who said, do whatever you can to save me. Those people died faster. Which would you rather be? I'd much rather be in hospice with my family in a nice room without, a bunch of things hooked up to me. So we'll see a quote. More fundamentally, the focus must shift away from treating illness toward preventing it. 70% of its spending on long-term illnesses, cheaper as well as better for patients to reduce obesity. NHS providers are paid for the procedure they carry out, not for those they render unnecessary. The better model, we give health providers a budget based on population they serve and pay them according to their ability to meet targets of better public health. We're going to see that. Again, that's Porter. Porter says you don't get paid for treatments, you get paid for your population size and how healthy they are. So the statistics are how healthy your population is. There's that word, incentive. incentives for hospitals, incentives for patients as well. Another NHS. Some of this is out of date, but it's so true today because it's even a bigger crisis today. So it's been fairly interesting. Forcing many to wait months or even years. Their staff are leaving. People are barely live any longer than they did a decade ago. Some want I mean, you think I'm talking about on some of these quotes the U.S. system. So UK's, other than the long wait times, the U.S. and UK have some similar problems. Some want to overhaul their model, switching from a system funded by taxation. Others want to have means tested, so actually having the people in UK pay for their medical care rather than just doing it through taxes. It's become a sickness service, not a health service, but to spend it productively requires a shift in focus away from hospitals to the community, from treatment to prevention, from incentivizing inputs to encouraging better outcomes. That's going to be very much Porter. The critical question is where the money is spent. At the moment, the answer is that question can be boiled down to one word: hospitals. Spending on public health and social care has fallen in real terms over the past decade. The share of total UK spending allocated to primary and community care has fallen even before COVID. There's this more recent article. The share doled out to hospitals has risen to almost 2/3 as a share of GDP spent by rich governments. Compulsory insurance schemes, only America spends more on hospitals. Hospitals is a big deal in the United States. We always think pharma. Everybody hates pharma, but hospitals are a big deal in the United States as well. This makes no sense. Hospitals is one designed to treat people only after they have become really sick. That is the equivalent of buying fire extinguishers while dismantling the smoke alarms. The majority of health and social care spending now goes to treating long-term conditions like diabetes, high blood pressure, and arthritis. Such conditions are managed by the patients themselves in their own homes and with the support and networks of general practitioners and local specialists. So moving out of hospitals into communities to focus on prevention, keep people healthy for as long as possible. Socioeconomic factors, genetics, and individual behavior matter more. Obesity is a big issue in the UK, as it is in the US. In fact, one of our best exports is bad food. We're really good at exporting bad food. I remember in your age where I could eat what I wanted to, and then that carried into my 30s, and it didn't work so well in my 30s, especially when you get a desk job. It's tough, right? And it's whose fault? The food industry doesn't help much, does it? A lot of unhealthy food that's really cheap. But that's now true. It bugs me going to Costa Rica and seeing Taco Bells. It's just horrible food, and the lines are long. For some reason people love America's just processed fatty foods. The way the NHS measures and motivates performance also needs to change. The system is geared toward inputs. Politicians make promises. Top-down metrics based on activity encourage hospitals to spend billions on unnecessary unwanted treatments. All right, so just proving this is not a U.S. only problem. It's just exacerbating the U.S. because of our tax system. All right, there's another UK article. I don't think this is going to fly in the UK. The UK is healthcare is just provided to you as a UK resident. There's been some debate because they do have a lot of immigrants, obviously with all the wars going on and the cost of the system getting out of hand and who's paying for what and how much are people paying their fair share and all that. But unlikely now, right? Labor's probably going to win the next election. Labor's certainly not going to challenge this. Neither party is going to challenge NHS. It's just too sacred. And yet it's kind of like Medicare and Social Security in the United States. Everybody knows it's horribly broken, but no one's touching it because it's just politically dangerous to do. So again, UK needs to reform, but they're not going to. 90% of Britons believe the NHS should be free at the point of delivery. 84% think NHS should be funded primarily through taxation. So who's going to propose something different? Those are pretty tough numbers to fight against. All right, here's I forgot I had this in here. Yeah, this is a good chart. I forgot I had a more recent. This is probably the main reason I put this article in here. So you need something at the beginning to define the problem. So here's one on hospitals. Just to show you in the US, well, it's all healthcare. Healthcare spending as a percentage of GDP. That's a really good one. And it's 2020, so it's more up to date than some of the other numbers I've given you. So I would probably put a chart like that at the very beginning. And you can use it just like this. The Economist is enough for your source. I don't need any more than that. You see, Britain is pretty inexpensive, but look at its hospitals. So U.S. is really high on day case and outpatient care, but UK and U.S. is not that much worse than UK when it comes to hospitals. All right, everybody got that one copied in? Family doctors, community nurses are the best place to manage these chronic conditions, yet only 8% of their budget goes to general practice. It gets worse. Hospitals are primarily paid on base activity. We've already seen that one. The system does not just suck patients into hospitals, also keeps them there for too long, in part because of the shortage of carers. More than 1 in 10 beds are occupied by people who do not need them, 10%. Now, in the video, that one doctor at the end, he said geography is destiny. How long you stay in the hospital depends on what city you are in. And they said it doesn't make sense that doctors that are trained exactly the same way treat patients very differently depending on whether they live in Dallas or in Los Angeles or New York. Doesn't make any sense. Why would that care make any difference? Why? Because hospitals have that control. That's that asymmetric information. Hospitals are one that say, I think you should stay another night because we make more money if you do. They probably not going to say that, but you know, if they have extra beds, why not? Hey, why don't we keep you here one more night for observation? Are you going to challenge that? I probably would after watching these videos, but you know, does the doctor want you to do that? You know, they're probably going to have you sign some release. They say we need to observe you, you go home and you die in your sleep. They're probably where you're going to sue them. The second crucial building block reform is technology. There's an awful lot still to do in this area, less than half of their data platform to help them manage the population's health. You got that in the video as well. We don't have evidence. We don't have data. We're just, the one guy made the example of you're flying a plane. You don't know how much fuel you have. You don't know what your altitude is. You're just flying blind. And that's what he says is going on in this particular industry. Another NHS article. I don't know why I have so much NHS in here other than I get a lot of articles from The Economist, and I find it fascinating that they're having so many troubles. Very similar to what we've already seen in the other articles. This is true in the US. Most hospitals don't know what they buy, how much they buy, and what they pay for goods and services. There is a huge variation in costs and outcomes. For hip replacements, hospitals pay between $788 and $1,590 for similar prosthetics. Rates of deep wound infections and avoidable complications vary from 0.5% to 4%, reducing the average to 1% will improve lives of 6,000 patients and save 300 million. More true in the US probably, but true in the UK as well. Too many hospitals again. Yeah, I like this quote. Specialized care is better at scale. Don't go to your community hospital for a major surgery. You might be the third patient. You should And if you can fly, you should fly, even if it takes you a few hours to fly there. You're going to be better off with someone who's done thousands of these things. All right, so accountable care organizations, they mentioned that in the video. You organize healthcare where you have a single provider responsible for all healthcare in the area. It's paid for outcomes, not activity. It's given a budget adjusted for health of the population. As long as it meets its targets, it keeps the margin. I'll put that in the Porter section because it's what Porter's talking about, just so you have kind of a start to that. It's at the very, very bottom. I do think the phrase well, in the Affordable Care Act, I don't think it's accountable care organization. I think it's affordable care organizations, but it's still the same type of thing. So the key is you have this gatekeeper kind of practitioner who's in charge of everything for you. You don't, like right now, I'll go to like 3 different doctors and none of them, they don't know each other. They don't know what I'm doing. They have no clue. That's why I say frustrated. I have to do a blood test for each one. Why can't I just do one for all of them? What they're saying now is your responsibility is one person, one organization. They know everything you're doing. They're going to make sure you're coordinated, that you're not doing something here that you could be doing over here, that they make sense together. So single provider responsible for an area, paid for outcomes. And its budget is adjusted for the population. So if you're in Florida, you got a bunch of senior citizens, that's going to be different than if you're in another city with a bunch of young people. They're going to make that adjustment for you so that you can, you don't get penalized because you got a lot of sick people just having to live where you live. It's a great concept. We're going to talk about this more. That's a great way of talking about it. Move from volume to value. You're going to definitely see that with Porter. And remember, with Porter, value is outcomes and costs. It includes costs. It's not just value as far as how healthy the person is. It includes the cost. Even if the person is not paying for it, their insurance is paying for it, it's still the total cost. Total health over total cost. All right. These are some older numbers, but this is the introduction section on just how bad is this problem in the United States. America's health hospitals are the most expensive part of the world's most expensive health system, trying to draw patients out of hospitals into cheaper clinics. America has almost 6,000 hospitals, with nonprofits outnumbering for-profits by nearly 3 to 1. Some people say profit's the problem, but the majority of our hospitals are not for profit. So I have worked for not-for-profits that are really focused on making a lot of money. It's kind of interesting to me that goes on, but most of these share a familiar business model, sell as many services as possible at the highest price. Doctors receive a fee for each treatment, so there are a few financial incentives to keep patients well. That's a good quote for treatment over prevention. I don't know why it turned it blue. All right, here's another chart, but the chart I gave you is more up to date. This one's 10 years old, just to show you how expensive hospitals are versus they don't even have the UK on there. So use the more recent chart, makes more sense. Employers have increasingly required their workers to make out-of-pocket contributions toward the cost of their care, which makes them a bit less likely to seek. I don't like that a bit less likely to seek treatments. That's part of the question. Is there an elasticity to demand for healthcare? If people have to pay an extra $500, $1,000, will they start thinking, you know what, I'd rather keep that money. Maybe I don't need the knee surgery. Maybe I don't have to go to that hospital. Maybe I can drive an extra 10 miles and save money. The Affordable Care Act also includes incentives for hospitals to provide quality rather than quantity. I don't think it's done much yet, but groups of doctors and hospitals can apply accountable care organizations or ACOs, which will be rewarded for um, keeping the cost of Medicare patients' treatments below a certain level. The most seismic shift, however, is to move away from fee-for-service. How can a hospital profit from delivering fewer services when it is organized to deliver more, rewarded for keeping patients well, as opposed to paying it by the quantity of treatment? You're seeing that going to come back and forth and forth. That is what Porter's going to say. Ensure that patients do not suffer expensive relapses. Nurses scroll through records to confirm that patients have collected their prescriptions and had their checkups. More home visits are being made to recently discharged inpatients. There's part of the solution. I don't remember where it goes. Yeah, I don't know exactly where it would go in here, but it certainly makes sense. I might put it under technology. I don't know. I might change my mind on that. So relapses are pretty important, but you know what that doctor said? I'm paid to harm my patients. Relapses is income to the hospital. How do you get it so that relapses are not income, but actually a detriment to the hospital? That they're actually penalized the more patients that have to go back because of infections or whatever surgery mistakes that they made. But also making sure patients are doing what they're supposed to be doing. Home visit seems really expensive, but if a home visit prevents relapses of people coming back to the hospital, it's a cost benefit analysis that you got to do. All right, so let's so up here, I do count off if you don't do this one because I do think it's pretty important. I just got to find it. So under, I already have it there, surprise bills. Let's talk a little bit about that. So under complexity of system and lack of price transparency, surprise bills. Now here's something you could get for the 5%. I might have mentioned it last class, but there has been recent legislation on surprise bills. You might want to look that up and see exactly what the legislation said. But let's look, some of these things are pretty shocking. A lack of market competition has allowed hospitals to thrive while patients get hit with exorbitant, unexpected, unfair bills. Elizabeth was stuck with a bill for $17,850 because a physician asked her to provide a urine sample. She didn't know what the doctor's testing lab was out of her insurance network. Her insurer, Blue Cross Blue Shield, would have paid $101 for their service. They refused to cover the bill because it wasn't in her network. Fearing for her daughter's credit rating, the father bargained the bill down to $5,000. How many of y'all would do a urine test for $5,000? That seems a little excessive, doesn't it? Why are they doing that? Because you're out of network, you're kind of stuck. They negotiated down to $5,000. Most people think that should be illegal. Or at the minimum, they should tell her up front, hey, this is not in your network. You could get a bill for that. Don't you think that would make some sense, right? Similar to, remember, life insurance on the tax issue. Hey, you might need a tax attorney. Hey, you may get a $17,000 bill in the mail. Tens of thousands of families who receive medical bills every year. 22% of patients receive a bill they did not expect. McAllen, Texas is, you hear them a lot. They tend, I don't, any of y'all from McAllen in here? Yeah, have you used their hospitals at all? Or they don't do well in these articles. Have you heard any rumors while you were there? So I don't know what it is. Maybe because they're just so far from everyone, right? It's a pretty long drive. You probably don't go home every weekend, I would guess. Already infamous for being the highest cost county in the U.S. for Medicare. 89% of them received balance bills from doctors who didn't take their insurance, even though the hospitals they visited did. You would just assume, right? The hospital's in my network, then obviously everyone's in my network. But a lot of times an anesthesiologist will be out of network so they can charge more. And, it's kind of a racket. This guy, he needed neck surgery, received a $117,000 surprise bill from an assistant surgeon he hadn't known about or met. The assistant surgeon's charge was almost 20 times the fee of the primary surgeon. Should that be legal? Right. First of all, this guy's going in for surgery. So is this someone who should be making last second financial decisions? You'll see this one guy who's pretty sharp. He's going to make the decision while he's on the gurney being rolled in, but this is not the time for these people. This should all be worked out in advance, and you should know that. That's a pretty hefty bill. Now, he probably got it negotiated down, but still, it's going to be thousands of dollars out of his pocket. The hospital physician may charge $3,000 for a service, but the insurer will disallow a big chunk of that and only pay $750. The real price is $750. The $3,000 is just fictional, plucked out of thin air. But when an out-of-service network provider bills a patient, no discount is applied. The insurer then pays the same $750, leaving the patient responsible for the $2,250. The out-of-network provider has no duty to accept the insurer's payment. The phony made-up price suddenly becomes very real. The AMA, the real crux of the problem is that health insurers are refusing to pay. Now, the AMA is saying, no, 3,000 was the real number. 100 and whatever thousand, that was the real number. The fact that we're only getting paid $100, that's what that's our problem. That's the problem. We're not getting paid enough. Insurers, in turn, accuse doctors of price gouging, hospitals of being complicit. It's the hospital's responsibility to contend to ensure that all physicians treating patients in the facilities are covered by the same insurance contracts as the hospital. That makes perfect sense to me. You shouldn't walk into a hospital and not know who's in your network, who's not, and what you're going to be paying out of pocket. Again, take it back to your car. You take your car into the shop, and they say, oh, this is all covered by your auto insurance. You say, oh, that's great. And then you could car back and say, well, we had to replace the engine, and that was $80,000. And that's not covered by your insurance because we used someone outside. You would be pretty upset, right? What are you going to do with your car? They're going to tell you an estimate. If the estimate goes up 5-10%, what are they going to do? They're going to call you, right? You're not going to come back and it's going to be 80 times more than what you thought it was going to be. But in medical care, no, they don't tell you, and then they charge you. Other hospitals seem to go out of their way to create opportunities for surprise bills. Many hospitals have no in-network anesthesiologists. After having her thumb operated on, Ellen was balance bill for $6,300 for a thumb. If you think how much can you charge for a thumb, but $6,300. Doctors gain by remaining independent. They can still collect in-network payments from insurers, and they can extract additional dollars from patients by balance billing. Refusing to join their network is a dominant strategy for independent physicians. And that's why anesthesiologists do that, because they are pretty independent. They can roam around and help different hospitals. It's a fairly, technical field that you do similar things everywhere you go. They're perfect. Go work in multiple hospitals, be out of network, and get a little extra money over what the insurance pays. All right. Here's one on overdiagnosis. I forget what the guy in the gurney is. We'll find him later because it's an interesting one. If it doesn't come up, this is a guy on the gurney getting rolled in, about to get a surprise bill. And he says, forget it, I'm not doing that. And he says, unless you negotiate what I'm paying you before you operate on me, I'm not going into surgery. Now, can you imagine doing that when you're about to go into surgery? That your mind would be that sharp, but hopefully we'll see it. I'm pretty sure it's in here, but okay. So we're paying more. So part of your introduction, you probably want to put in the introduction, we're paying more in the US, but the outcomes are worse. We're not healthier because we're paying more. We're actually less healthy and we're paying more. Now, is that because the healthcare system isn't good or is because of our lifestyles. So you can ask that. So we spend 12,345 a month on patients in Western Washington, British Columbia, and Canada, about half that price. American patients in Washington, you're talking about what, a few miles apart from each other. Washington patients, colorectal cancer survived 21 months. In British, it was 22 months. So they paid half as much and they lived an additional 0.7 months. So the quality care is about the same, but the cost was twice as much in Washington versus right across the border. I assume British Columbia is across the border from Washington. I don't know my Canada states very well. Um, Here's something else you could do for that. Other is the recent law passed to let Medicare negotiate. I think I have an article on that here somewhere. At the time this article was written, they were disallowed by law from negotiating prices. Under current policy, U.S. Health and Human Services explicitly forbidden from negotiating directly with drug companies on behalf of people in Medicare. The program's plan, Medicare accounted for 29% of spending at drugstores. Donald Trump has repeatedly criticized the policy, and most Americans want it changed. And so under Biden, there is a law. So how strong is the law? And that's part of the debate. Is it going to work or not? A lot of the pharma side are saying it's not going to work because there's no negotiation here. We're just being dictated to us. We're being told what price we can pay. And if that's the case, we just won't provide the medicine. So they can take their toys and go home. You can't force them to do things. So they do have that power. So if they're being underpaid, they'll just stop providing the drugs. So lack of price transparency, patients don't know what they're paying for until they get the bill. Prices of hospitals vary widely, sometimes even in the same zip code. If patients knew what things cost, they may shop around for a better price, and that might encourage hospitals to charge less. That's a good quote in a couple of places. You could certainly put that under price transparency, but it's also in the solutions. Under consumerism, for consumerism to work, I think we have to have a few things. Got to be price transparency. People want to know what it costs before they go in. And there's got to be skin in the game. The consumer's got to be paying more. If it's being paid by insurance, they don't care. And then there's got to be information on quality. So if all you have is price, most consumers assume higher price means better quality. That's just the normal thing that we do. So consumers got to know the price. They got to be paying for a big chunk of it. And they got to have information on quality. If you have those three things, I do think consumers will shop around. So you could certainly quote this article on that. Administrative costs for healthcare are high, more than twice in Canada. This is part because the American health system is fractured, meaning a doctor's office spends a lot of time on administrative tasks like filling out paperwork and chasing insurance companies get paid. Canadian hospitals get a lump sum budget that covers the cost of care. So the health insurance system does create a lot of costs in the United States, especially given that almost everything's covered. In the UK, it's not a problem because you have a single payer. There's no health insurance. It's just everything's just part of the contract. In Canada, it's a budget that you get. So there's no paperwork. In the US, there's a lot of paperwork, depending on who the insurance carrier is. Okay. Questions, comments up to there. We're jumping all over the place because that's the way the articles are written. All right, let's jump to overdiagnosis. So the way I look at overdiagnosis, I look at it as first define it, and then give me a couple of really good meaty examples. What does overdiagnosis mean? The video gave you some really, really good ones. We'll probably see some good quotes in this article. But Overdiagnosis doesn't mean fraud. It doesn't mean the doctor is intentionally treating someone who doesn't need it. What it means is exactly that prostate cancer. You got 15 people who have prostate cancer. 14 of them don't need the surgery, one does. Overdiagnosis means we're overdiagnosing 15 people. But what's the problem? I mean, 14 people. What's the problem? We don't know which of those 15 is the one. That is overdiagnosis. And what do you do with that? Do you just not treat any of the 15 and then one of them dies? You treat all 15 of them and 4 or 5 of them have, didn't need it and now they have complications afterwards. So that's what they mean by overdiagnosis. The notion that evidence might be used to limit care remains heretical. About 1/3 of that spending is waste. You're going to see a lot about that. Oh, this is a great quote. I'm going to put this. You notice a little bit above here, it says fraud and waste in the system. That's a piece of cake too. Just give me a couple quotes. You're going to see that 1/3 a lot. I don't know the source of it, but a lot of people use it. 1/3 of our healthcare spending is waste. What do we mean by waste? It means if we didn't spend it, our health would be exactly the same. It's money we're spending that's not making us any healthier. That's waste. I'll show you another article or from the book where some people think it may even be over 50%, which seems pretty extreme. But 1/3. How do we fix that? Anybody know what that is? Can you guess? It starts with an E. What does E stand for? What word did I just point out? You know what the M stands for? What's M stand for? So what's the B? Evidence-based medicine. We hate that in the United States. I mean, it's shocking in that video. It's like we have all these doctors doing stuff and there's no collection of data. What could solve this? What are we all talking about today that could solve this? What's smarter than all the rest of us, all of us put together? AI. That's more of a solution, but I put it there. Americans hate evidence-based. I just talked, that one doctor who says, hey, but evidence shows it doesn't make sense. But when you're talking about your wife, suddenly we don't care about evidence. It's like, it makes no sense at all. That's just kind of a ridiculous thing to say. So AI is making huge, we'll see a few articles. AI is making huge inroads into the healthcare system. This is what I would like. I might talk about my thyroid issue, but I think I was defrauded because of lack of evidence. And if I were to have that to do all over again, I would do it radically different this time than I did. All right, so Affordable Care Act put $1 billion in there for evidence-based medicine. What did it do with that $1 billion? They're explicitly barred from studying the cost effectiveness. They're essentially going to spend $1 billion to study, but they're not allowed to use it. Talk about a good use of taxpayer money. Let's spend $1 billion, but make sure you don't use it because we don't want evidence-based medicine because that's going to limit doctors and what they can do. We want doctors out there treating people without evidence because they're the experts, right? The task force unleashed a torn flurry. We talked about this. It recommended against mammograms for women in their 40s. Last month, the task force advised against routine PSA tests for prostate cancer. The panel explained that for every life the test saves, the treatment inspired those tests would cause 1 man to develop a serious blood clot, 2 to have a heart attacks, and at least 30 become impotent or incontinent. Or how many? Yeah, so 1 versus 1, 2, 3, 33. 1 guy saved 33. Pretty bad outcomes. Called the task force what? A death panel. The health department promptly confirmed that Medicare would continue to pay for those PSAs. They were called inappropriate, irresponsible. See what happens when you use evidence-based medicine. You're a death penalty. You're killing people. How can you tell women not to get the test? How can you tell men not to get this test? You're all going to die. You could probably pull some of that in. That's pretty interesting stuff. I mean, I'm you're that other is could be as easily as go onto the internet and say, should I get a PSA test? And just see what articles come up. Or should I get a mammogram in my 40s? Do you think anything would come up on Google on that? What's going to come up first? The people who have skin in the game that make money off of the test, or the people who are trying to reform the system who can get no benefit, they reform it. The people with the most skin in the game are going to have the most power. Theirs is going to come up first. It's just the way the human brain works. Some more on overdiagnosis. You can't tell me how prostate cancer and that we're just going to watch it. On the PSA, what did that last guy say? So you had, was it 3 or 4? I kind of lost. So yeah, stop. I was talking about that. So PSA, the first guy got the surgery, something happened. The second guy got that really, really expensive treatment. That's the guy I kind of bugged me. I don't know if he bugged y'all, but there's something about that guy. Like life as we know it has come to an end, and like, okay, let's kind of go back. But I guess if you're worried about having cancer, that makes sense. But it's a little much. But he had that really, really expensive treatment. It sounded like he spent 70,000 out of his own pocket. So I guess more power to him if he's going to pay for it. And then the third guy, what did he do? We'll watch, monitor. It gets worse. We'll get surgery. Pretty rational, calm conversation. You're safe for now. That's a dangerous thing for a doctor to say, isn't it? 2 months later, he dies of cancer. That's a dangerous thing. But the doctor says, you're safe for now. Let's monitor it. We'll see how it goes. And the guy seemed perfectly comfortable with it because his focus was, I don't want adult diapers. I don't want that change in my life. If it's safe for now, yeah, let's wait. There's a good chance you'll die with prostate cancer, not of prostate cancer. And there's a big difference. If you knew you were going to die with prostate cancer, but not of prostate cancer, would you have the surgery? And my guess would be no. Why would you have the surgery? It's not going to have any impact on your life. What we know now called cancer maybe shouldn't be called cancer at all. Cancers are heterogeneous and can follow multiple paths, all of which progress to metastasis and death. And new technology increasingly able to find abnormalities. When we do, our inclination is to act, and when the remedy turns out to be far more harmful than the disease, had it run a course. I'm going to put this under the technology problem. But remember, one of my complaints with the Affordable Care Act and with that second article is healthcare's got to pay for doctor visits because they've got to find stuff early. What is this saying? You're probably better off not finding it because they find it, they got to do something. And you probably would have, there's probably a 90% chance if you hadn't found it, you would have been great the rest of your life and nothing would have ever happened. So is technology making us healthier, or is technology just finding smaller and smaller little blips in our bodies? Oh, here's a great quote for the overdiagnosis. Sorry, I'm jumping around again. Americans tend to be over-tested, overdiagnosed, overtreated across a variety of conditions. Now, why are we overdiagnosed? Because we're overtested. If you solved one of those in the mammograms, testing women in their 40s, what are you going to do? You have more overdiagnosis, and what's that going to lead to? More treatments. I don't think they should even do PSA tests for men in their 80s. It's just, yeah, it might kill them, but there's a good chance it won't. why spend the money on the poor 80-year-old? He's probably going to die of something else. Salary physicians who receive no income. All right, so here's the other thing you say, well, if the incentive is to overtreat, then the solution's got to be salary physicians, but frustratingly, it's not. Salary physicians who receive no income from higher volume and had limited liabilities ordered as many tests as the more traditional. So you can't just go with let's change the incentives, get rid of those commissions kind of payments. We have an exaggerated perception of the benefits of tests. I think the video said people walk into a hospital and they just want, or the doctor, I want you to do something. And the doctor's like, I don't have a clue. That doesn't sound good. And say, well, let's run some tests. That's what they want to hear. Yeah, let's run some tests. Yeah, I've had this headache. Let's run some tests. That makes them feel better. The doctor's like, yeah, why not? No harm for me. I make more money, and makes them feel good. Some patients are diagnosed with cancers do not need to be treated because that cancer is never going to bother them. The problem is that we don't know who those people are. That's another good one for overdiagnosis. It's a good definition. Doctors know that approximately 10% of localized lung cancer tumors and 20 to 30% of localized breast cancers found through screening would never cause harm. That tumor would just stay there, never grow. The rate is even higher for prostate cancer at 60%. That sounds lower than the 1 in 15, the 14 out of 15, but still. And I don't know if y'all noticed on the prostate cancer, what he said is a lot of people are going to get tested and get surgery that they didn't need. Or if you're told, that you do have it, good chance you're going to die anyway, because it's by the time they see it, it's going to be too late. So even the people that catch it early may not work because they have a fast progressing. And that gets back to there's different cancers. Just because you have prostate cancer, not all prostate cancers are the same. Some are fast progressing, some are much, much slower. And the diagnosis itself is going to make people anxious. The Cancer Institute group recommend reducing frequency of some screening, focusing on screening on high risk groups, and raising requirements that would lead to biopsy or other follow-up care. There is that evidence-based medicine. So we have some of the data and people are just ignoring it. So even though you have the data, people are saying we don't really care. We're not going to follow their pronouncement. National data demonstrates significant increase in early stage disease without proportionate decline. So what do we have today? We have pre-diabetes, pre-hypertension, pre-heart disease. That should reduce the incidence, shouldn't it? But it doesn't have any impact. So what do? They reduce the numbers. So more people are caught. See, we'll catch them early, and yet there's no benefit on the other end. We're not keeping people, they're not living longer. They're not avoiding surgery more. So screening for breast cancer and prostate cancer appears to detect more cancers that are potentially clinically insignificant. In contrast, so when does it work? Colon cancer is effective because early detection is really effective. I wish I had this table updated. I like this table. It's a little confusing, but I like this table. But here's where I'll talk about thyroid cancer, because they said prostate cancer was the poster child. Look at thyroid cancer. In 1975, 5 out of 100,000 people were diagnosed with prostate cancer. In 2010, it was 14. So there's a 185% increase in people diagnosed. So you would think, wow, think of all those lives we saved, right? An extra 10 people out of 100,000, we caught them early, diagnosed them so they could get treatment. What happened to mortality? It barely budged. 185% increase in treatment and a 7% decline in mortality. That seems like a pretty big difference. But you can look at these other numbers and look at the impact. Prostate, 54% increase, 30% reduction. That 30% seems pretty decent. Colon cancer, fewer diagnoses because the tests are much better, and a huge decrease. Same thing with cervical cancer. Fewer people are being diagnosed because the the tests are better, but fewer people are dying. That's effective. That's what you want. So I'll just finish with thyroid. So in my case, I had my thyroid taken out. I wish I hadn't. I don't trust my doctor anymore. I think he was a scam artist, but I don't know that for sure. But what I wish I had done was got a second, third opinion. But what I should have done is ask them some questions. So here's the questions, and y'all can kind of guess what the doctor would have said. What is my probability of dying of thyroid cancer? That would have been nice to know. Based on what you know right now with the test you've done, what's the probability of dying? What is prob of dying in surgery or infection afterwards? I'd like to know that, right? What if this is 0.5% and this is 0.3%? That would have been nice to know, right? What is prob of cancer from all post-op radiation? Oops. Yeah, I kind of should have said it like that. Now, how serious was that radiation? Well, the people who walked in my room were in hazmat suits. That means they probably did something that's kind of dangerous to my body, wouldn't you think? If people, I'm drinking this stuff, they're just 6 feet from me in hazmat suits. So I'm thinking I couldn't go to HEB and go shopping just in case a pregnant woman was within 20 feet of me. I mean, it was insane. Is there a chance that could do me harm in my future, do you think? And what's the probability, or what if that probability is 0.3%? Should I have the surgery? Sounds like I'm more likely to die with the surgery than without the surgery. But if I'd asked the doctor that, what would his answer have been? He wouldn't have gotten mad at me. Now, what did he do? He operated me twice, 2 different days. His argument was, we'll take the left side out. If it's cancerous, then the next day we'll take the right side out. When did he know he was going to do 2 operations? He said after the first operation. When do you think he really knew? I think he knew before the first operation. There's almost no doubt in my mind that he knew that he was going to operate on me twice. Why did he operate on me twice? Twice as much money. Yeah. So you see why I'm furious at this. So I wish I had watched that video before I had done. The thyroid cancer is not in that script, but it's there. I was listening to an NPR thyroid doctor, and she was talking about her friend went the exact same thing I did. And then she goes, but thankfully my friend didn't have the surgery. And I'm going, yeah, why didn't I talk to you before? It would have been kind of nice. All right. We're getting close to the end. Everybody, y'all stay with me this time. Y'all can see we got a few things that are going to be pretty easy to fill in, but we're getting pretty close to getting something everywhere. So, all right, we'll stop there.